Hello and welcome everyone to the Team FRCR to be Viva practice session. I'm very thankful to Dr. Laila Adel Mohsen today, who will be conducting today's external session. She is our team member and she's a consultant radiologist working in University Hospital of Sharjah, UAE. And she's also assistant professor of radiology, Minya University, Egypt. Dr. Laila recently cleared her 2B exams in September. And we are really thankful and grateful that she has agreed to do this session and share her experience and tips with us. Over to you, Dr. Laila.
Thank you so much. Thank you so much. I will go straight forward for the practice, and then I think we can discuss any related experience in the meanwhile. Okay. So for Dr. Asad, you can see my screen.
Yes, hi. Yes, I can see your screen. Yeah.
Okay. So you can start this.
So 35-year-old female presented with right lower quadrant pain for a few days. So can I move the next slide?
Yeah, sure.
So this is the ultrasound image of 35-year-old female presenting with lower quadrant pain. I can see it's ultrasound image of the pelvis of the female, which is showing uterus is being measured and endometrial thickness is being measured. And can I see any other?
Yes, you can proceed through the images, please.
I think I need to request
okay.
you for
Control. Okay. Can you send me your name?
I'm just trying to figure out where do I need to go to for this.
Yeah, I found.
Yeah. Sorry, I can't. I'm clicking on it, but it's not opening. It's not moving.
Yeah, Dr. Asad, you clicked on the screen and still it's not moving?
Yeah, I'm clicking on the screen, but it's still not moving.
I think you'll have to drag the images. It's not scrollable. You'll have to drag the images from your left-hand side. Oh, did we lose Dr. Laila?
Yeah,
I think so. Okay, we'll wait for her.
Okay.
I'm pausing the recording.
Okay, now it is moving. So I will just try to go through all the images. Okay, I think this is an ovary which is being measured, and then this is endovaginal scan image of the ovary. I can see there is a gestational sac which is identified, but it is, yeah, so it is not within the uterus, but it is outside the uterus and the gestational sac. So I suspect it can be a ectopic pregnancy, and I don't see any evidence of free fluid. And
can you point it out, please, Dr. Asad?
so this area, is this the gestational sac or?
No, I feel this is a normal follicle.
All right, okay, so this is normal. Anyway, so in this case, I think this is a large ovary. Is this, there is no indication if this is right or left, but I suspect this is a large ovary with this follicle, and there is, it is showing, and I don't see any vascularity within it. I am suspecting for ovarian torsion in this case. And so I need to communicate the findings to the referring team. Gynecological team review should be advised.
Okay, fine. So next case.
A 10-year male with cough and fever. So this is the frontal chest radiograph of 10-year-old male presenting with cough and fever. The striking abnormality is in the left upper lobe. There is a cavitating lesion which is present, the left lung upper zone, and which is showing associated perilesional thickening, and the left hilum is mildly prominent. Otherwise, the rest of the lungs are clear. I don't see any obvious bony abnormality. So in 10-year-old presenting with fever and cough, the main differential is cavitating pneumonia. And I would like to review previous images if available, and so it needs to be communicated to the referring clinicians for follow-up within 4 to 6 weeks after appropriate treatment.
Okay, so there is no previous imaging. Any other differential for this cavitating lesion?
Cavitating pneumonias, and then it can be cavitating other abscess, a lung abscess, or it can be in 10 years old. I'm thinking about granulomatosis, but it is less likely. But it can be a possibility, and then less likely to be metastatic deposits. So my top differential is cavitating pneumonia or fungal infection, or tuberculosis as well can be a possibility.
Okay, so what will be your next management to rule out that, or at least confirm one or two of them?
So to confirm or rule out these possibilities, I would like to, for the sputum cytology and advise, and further CT chest can be taken, and to take it for the and sputum cytology is the mainstay.
Okay, so
Or
next case.
AFP as it was bacilli.
Okay.
Abdominal pain, 30-year-old male with chronic constipation for over 3 months. So this is the frontal AP radiograph of abdomen, 30-year-old male, chronic constipation. And I can see there is fluid level, which is present in left side of the abdomen. I think this is likely to be small bowel. And fecal loading is seen in the bowel, large bowel predominantly. And no abdominal calcifications are identified. I don't see any obvious abdominal mass. In the pelvis, I can see there are some lucencies projecting in the pelvis.
Where exactly can you see them?
So these areas, and in the left abdomen, I can see there is some lucencies over here as well.
We cannot see your mouse, Dr. Asad, please.
Can you see my mouse? Sorry.
No, just click on the screen, and so it starts moving. Yeah. Okay.
So yeah, so these areas, and also over here in the pelvis.
Mm-hmm.
So otherwise, I don't see any evidence of pneumoperitoneum. No abdominal mass, no calcification. So to take this further, presenting with abdominal pain, we can proceed with CT, CT abdomen pelvis.
You will go straight for CT?
I'm just trying to make out, is there any possibility, because I think there is some fluid level which is present in the bowel, which I'm suspecting it is fluid filled bowel, which is probably dilated small bowel. And these lucencies, I can't really make out what actually these are. So that's why.
Okay, fine. So actually, this is one single fluid level, so it is not sufficient to say small bowel obstruction.
Yeah,
and
is.
Patient is complaining for 3 months also.
Okay. So it's a long-standing problem. So.
Yeah.
So yeah, to take this further, I can't really make out on this single image. So probably I need a CT abdomen to take this further.
Okay, fine. So this is the CT of the patient.
Okay. So this is CT abdomen axial images, abdomen pelvis. I'm just trying to scroll, look. Okay. So the large bowel is predominantly showing fecal loading, and trying to make out. And I don't see any bowel wall thickening and no evidence of pneumatosis. And this area of sigmoid colon is showing some thickening, which is present within the pelvis. And with and come down within the pelvis, I don't see. So the rectum is showing, the wall of the rectum is showing irregular with some thickening as well. So I suspect, can this be a rectal tumor, which is extending proximally into the sigmoid? And so, yeah, it is showing thickening as well. So there are some perirectal lymph nodes which are prominent, and I would like to look liver for any metastatic deposits. Can you see on the coronal plane? So the visualized liver does not show any focal deposits. The portal vein is patent, and
Okay, so can you summarize this case?
so to summarize my findings, there is a thickening of rectum and proximal sigmoid, which is suspicious for a malignancy with some perirectal lymph nodes. So I will convey my finding to referring clinician and further with lower GI MDT, colorectal MDT discussion, and then CT chest as a staging should be undertaken.
Okay, so next case.
No clinical presentation.
Okay.
This one. So I am presenting with ultrasound image of the left kidney, and I can see there is irregular lobulated mass-like lesion, which is in the lower pole of left kidney, showing loss of normal corticomedullary differentiation, and with some vascularity. So I'm suspecting, can this be a renal mass? And so to take this forward, I need CT abdomen pelvis for this patient.
Okay.
So CT coronal images are presented, and which are showing this mass which is present in the left upper pole, irregular heterogeneous area, and it is I'm looking for the left renal vein, which appears patent, and
Can you point it out, please, with us?
sorry, let me make it up.
There is an axial also if you want to check.
Let me have a look on the axial. So, okay. So yeah, so this is the left renal vein, which is showing some thrombus, filling defect, and the IBC is not involved. So this is the proximal part of the left renal vein, which is showing filling defect. So there are some enlarged lymph nodes in the left renal hilum. So no focal liver lesions are identified. There is left-sided pleural effusion as well, and no adrenal nodule, and the rest of the abdomen, some para-aortic lymph nodes are also noted, and then there is some ascites as well. So this is a probably case of renal cell carcinoma by top differential, and to take this further, I need renal MDT referral and CT chest for staging.
So patient has high inflammatory markers. Is there any other possibility?
So if the patient has high inflammatory markers, then other possibility can be renal pyelonephritis, which can present like this, and with the filling defect within the left renal vein as part of infection, and some there is some stranding as well. So other differential is pyelonephritis.
Okay. So next case.
This is the X-ray, frontal and lateral radiograph of the knee joint, including the femur, whole of the femur. I am trying to make out. There is an abnormality in the distal part, distal metaphyseal region of the femur, which is showing some cortical irregularity, this area, and on lateral view, which is predominantly intramedullary, and I don't see there is any associated soft tissue mass. No, predominantly it is a lytic lesion, no chondrite matrix, and but I can't. It's to me it looks like a wide zone of transition rather than a narrow zone. So it looks like it is an aggressive process, although I can't identify any associated periosteal reaction or soft tissue mass. And rest of the visual joints spaces are intact with some moderate changes of degeneration and no joint effusion. So to take this further, I need correlation with previous X-rays if available. If this is the first presentation, then I need to communicate the findings to the referring clinician, and probably my differential may include infection like osteomyelitis, or it can be an aggressive osteosarcoma can be a possibility.
Okay, so what would you recommend next for the treatment?
So for this, to take this further, I need MRI of the knee to include both whole femur,
Okay.
including both joints above and below.
Okay. So the MR is here.
Okay, so the MRI, I'm just trying to have a look on the images first. This is the sagittal T1 fat set. On T1, I can see the abnormalities there, and which is showing abnormal signal within the marrow, associated soft tissue as well. And do we have a star? We
And
have, yeah, post-contrast fat set, which is showing increase enhancement within the soft tissues and also within this intramedullary lesion. So it looks aggressive, and I mean, the appearance is looks like to be osteosarcoma, and I can see there is some cortical breach probably, but so it needs urgent sarcoma team referral for the biopsy correlation and management.
any further imaging she needs?
She will be needing CT chest abdo-pelvis and for completion of the staging, and then probably a nuclear scan as well.
Oh, for now, while she's still in the department, any further imaging?
Probably CT chest abdo-pelvis.
Okay. So next case, last case.
5-year-old male presenting with nuclear medicine with congenital syndrome. Okay, and prior cross-sectional images. Okay. So these are the nuclear scan images of 5-year-old male who has a known syndrome.
Can you have a do you have an idea about the type of the syndrome? The type of the scan.
Is this a whole body bone scan? I can see there is an uptake within the liver, probably is more. So
okay, so this is an MIBG scan.
sorry, MIBG.
Mm-hmm.
Okay.
Yeah.
Okay. So since this is an MIBG scan and it is showing uptake within within the liver, and I think there is some uptake within this adrenal gland as well, probably. So I'm suspecting if this is case of neuroblastoma.
Okay, that's one good differential.
Or and the other differential may include pheochromocytoma as well. And as part of the syndrome, which includes MEN1 syndrome, which is it is showing some uptake within the parathyroid glands, I think. So can this be a parathyroid adenoma with pheochromocytoma and then medullary thyroid MEN2? It is MEN2.
Okay. So this was actually the question that I was going to ask. What are the syndromes associated with suprarenal masses? This is a pheochromocytoma, by the way.
Yeah. Okay. So then it is lone T1 and it is showing some enhancement on post-contrast. It is adrenal mass which is showing enhancement, and can it be adrenocortical carcinoma as well?
No, it is a pheochromocytoma.
It is a pheochromocytoma.
Yes.
Okay. So yeah, so pheochromocytoma can be part of MEN2 with medullary thyroid and parathyroid adenomas.
Okay, fine. So actually, that's well done, Dr. Asad. This patient had a von Hippel-Lindau tumor.
Oh, okay.
Yeah,
Right.
Sorry, von Hippel-Lindau syndrome.
Right.
For the nuclear scan, I'm not a professional with nuclear scan as well, but I tend to follow to see if there are bones, so it is a bone scan. If not, then I will shift to something else. There is no kidney and renogram, so it is not a renal scan. And I don't see the myocardium, so it's not a PET scan. Then I start focusing on the things that have uptake in the liver and the suprarenals.
Yes.
This is my way because I'm not professional. Sometimes find it difficult to know them from each other. Okay. For the previous case, first of all, you were right that it is not just this lytic lesion. There is a wide zone of transition here, as you noticed. But please be careful with the soft tissue lesions. So this is the lateral view. I expect fat lanes to be in here. So
probably it's not it's due to projection, or maybe
the image is not so good yet.
Okay. But,
this is the most important part, And for MR, like you said, it is an aggressive lesion. It's already breached the cortex and made an extra osseous soft tissue mass. If you are suspecting osteosarcoma, then I should scan the entire bone for other foci.
Okay.
But the metastatic workout is okay as well. But this is done, I think, after NDT meetings.
Okay.
And this patient, So you were right when you were right to suspect first of all renal cell carcinoma, but then when the raised inflammatory markers, then focal pyelonephritis or renal abscess are also another possibility, and they can also lead to renal vein thrombosis.
Yeah.
So for this patient, you are right. So here, considering the X-ray, this X-ray doesn't have much data in it, just the physical loading of the large tower.
Yeah.
But you can put, in the exam, there is always the first image is always an X-ray study. So just put for yourself the the regular steps. So for example, for me, I comment on the bones first, and then I comment on the calcifications, then the air, if there is extra luminal air, and what else? Then the renal stones. So it's like make it for yourself, and so you don't forget anything, and follow it schematically. So the patient did have a rectosigmoid cancer, and you are right to refer him for endoscopy and biopsy. And there is also this perirectal lymph node is also crossing the fascia here.
Yeah.
Okay. This patient, you are right to suspect either cavitating pneumonia or TB. This child did come from a rural area endemic in TB, so this was a case of TB. Please don't forget to mention that you need to isolate the patient at least until we know the result of the sputum analysis,
Right.
if he's TB or not.
Yeah. Okay.
Yeah.
Okay.
But otherwise it's fine. And the right lower quadrant pain. So yes, this was a case of ovarian torsion. Right ovary is mentioned here.
Mm-hmm. Mm-hmm.
Ultrasound images will be supported by the text to tell you which part you are looking, or otherwise, if not, then you can speak generally speaking. So this patient, oh yes, one more thing. When we suspect a surgical emergency, Dr. Khan once mentioned that you should show it to the examiner that you will act super fast. So you can say, I will pick up the phone and call the surgeon for this.
Definitely.
So yes, this patient, because she's complaining for several days, she had a hemorrhagic infarction of the right ovary.
Oh, okay.
Okay.
Yeah.
So, okay.
Thank
So
you so much,
Dr.
Dr.
Asad. That's very
Thank
good. Thank you. Okay. So next candidate, Sarat.
Yes, Dr. Laila, I'm here.
Okay.
I think, should I ask for the mouse control beforehand? Yeah, okay, I have.
Done. Okay.
So thank you. So this is a 60-year-old male, routine chest X-ray. So this is a frontal radiograph of a 60-year-old male with routine chest X-ray. I can see that there is a right-sided catheter in this patient in the region of SVC/right atrium. I can see that there is diffuse interstitial thickening in both the lungs. I have the impression that there is a subtle lucency along, I hope you can see my mouse, along the periphery of the left hemithorax.
No, you can ignore this.
Okay. I'm looking at the heart size, which appears to be normal. I'm looking at the trachea, almost centralized with a bit of kink in the distal part. I'm looking at the skeleton, especially at the distal end of the clavicle, the scapulae, the ribs. I did not find any discrete abnormality in the skeleton apart from the degenerative changes. I'm wondering, with the history of routine check in the 60-year-old male patient, the lung abnormalities are definitely quite conspicuous. This seems to be a case of interstitial lung disease. And I'm also concerned that why would this patient have a central venous catheter in situ? So I would probe more regarding the history of the patient, and I would raise the possibility of interstitial lung disease in this patient, and proceed with a CT test for further evaluation.
Okay, so this patient had a previous history of malignancy. He's currently under treatment.
He's currently under treatment.
Yeah.
Okay, so now I have been provided with CT chest, lung windows. I'm going to go through scroll through it once. So the additional information, clinical information I have been provided is that this patient is undergoing treatment for a malignancy. Now, as I scroll through in this patient from craniocaudally, I can see that there are multiple cavitating nodules in the right lung upper lobe with thick irregular borders. They are multiple. They are surrounded by ground glass opacification as well. Up till now, they are predominantly right lung. I can also see an area of ground glass opacification in the upper lobe with no cavitation here. There are subtle bronchiectatic changes as well. So now, and there seems to be tree in bud and miliary nodules as I progress towards the lung basis. So now my impression here is depending on the, okay, perhaps I should also look at the other images which has been provided to me. These are the mediastinal windows, and this is a 60-year-old patient. So as I am going caudally, I can see a soft tissue density in the anterior mediastinum, which is unusual in the 60-year-old patient. And hence it raises the possibility of either a nodal mass or a neoplastic thymic lesion. But I can also see soft tissue densities in the subcarinal region. So that therefore more I'm more inclined on reflection towards lymphadenopathy. So this is the lungs. I'm going to scroll down to look at the lung windows, to look at the upper abdominal window, upper abdominal sections. So in the upper abdominal sections, I'm trying to look at the adrenals first. So this is the stomach. I can see the right adrenal, but I cannot see the left adrenal very clearly. So I think it has been replaced by a soft tissue density in the adrenal gland, hence an adrenal metastases. In fact, even this is the IVC, the kidneys. So in the included lung windows, I'm highly suspicious for a left adrenal nodule, which could well be metastatic node lesion. I've also been provided with selected sections, axial sections of the cervical spine and base of skull, it seems. I'll have a scroll through it, I think through the neck. So these are again unenhanced. I'm scrolling down. This is without contrast. I'm going back cranially. I'm trying to look for lymphadenopathy. I'm trying to look for any obvious intraspinal lesion, although it is a bit difficult with the unenhanced CT. I still haven't been able to find an abnormality.
Okay, can you focus on the nasopharynx?
Yes, okay. So now going down with the emphasis on the nasopharynx, I'm going down. Sorry, I think I've scrolled too much down. Apologies. So this is the oropharynx. Now I'm going up. So now I'm at the level of the nasopharynx. It seems the nasopharynx pharyngeal tissue appears prominent, but I'm trying to look for any discrete mass. I believe there's a sort of asymmetry between the right-sided nasopharynx and the left-sided nasopharynx. So this warrant further investigation via flexible endoscopy by the ENT surgeon, and if needed, biopsy. I've also been provided with coronal unenhanced neck. And I think what the abnormality I can see here is a sort of asymmetry in the right side of the nasopharynx when I compare it to the left. In short, it seems that this is this is a 60-year-old male patient with a central venous catheter with cavitating lung nodules, some areas of miliary nodules and tree in bud, and a suspicious lesion in the nasopharynx. So this and the patient has history of being treated for a carcinoma. So in my opinion, with putting all these things together, this patient most likely has nasopharyngeal carcinoma, which are notorious for causing cavitating metastases in the lungs. And for that, this patient is having his chemotherapy. And I would compare it with the previous imaging, and discuss it with the oncologist and the referring clinician regarding the findings, who would decide about the further management in their MDT.
Okay, so next please.
Maybe click again. Okay, so this is a 40-year-old male with sepsis.
1 minute, yeah.
Sorry, 40-year-old female with abdominal pain and vomiting.
No, you are right. It's just scroll to the third, please.
Okay, I'll wait.
Okay.
Okay, so 40-year-old male with sepsis. So this is abdominal radiograph of a 40-year-old male patient who has presented with sepsis. I can see that there is a sort of tube which is going up to the left hypochondric region. This could represent a gastrostomy tube. I can also see that there are further 2 tubings coming across and ending within the abdomen. I'll just make sure that this is not outside the patient's body and within. I'm wondering regarding the nature of this tube. Usually in the abdomen, we see part of VP shunts or peritoneal dialysis catheter. There could be drainage catheters after surgery. I will correlate with the clinician regarding the nature of these tubes. Moving on, I can see that there is non-specific bowel gas pattern in this patient. I am trying to look at the part of the liver which is visible to me to see any linear lucencies indicating air in the portal vein. I can't see any in the view provided. The patient has presented with sepsis. I'm looking at the visualized skeleton and I can see there's a sort of, perhaps due to rotation or perhaps it is actually a sort of asymmetry in the skeleton with a tilt. There is deformity of the femoral neck orientation bilaterally.
I think this is just positional, so you can ignore it.
Okay, it's positional. The patient has presented with sepsis. So I'm trying now to look for any finding in this abdominal radiograph which can explain the area of sepsis, the reason for sepsis. I'm closely following all the bones to see if I can find any discrete lucency which could be a focus for osteomyelitis, a reason for sepsis. I do see a sort of lucency in the right acetabulum. If it's not positional, then this would warrant further investigation. It could be a part of septic arthritis or osteomyelitis, or even an aggressive lesion with a sort of component here, a soft tissue component.
Okay. So what would you recommend next? Because these are all positional, so you can just simply ignore them.
Okay, so patient has presented with sepsis. As I could not find any pinpoint reason for this, I would discuss with the clinician and proceed further, either with ultrasound abdomen as a first step or directly to contrast enhanced CT abdomen to see, to find a source of sepsis within this patient.
Okay, so the ultrasound was normal. So they requested the CT.
Okay, so now I have the coronal CT abdomen of a 40-year-old male patient who has presented with sepsis. This is the coronal CT images of the abdomen are unenhanced. I'm scrolling slowly from front to the back to have a look in this patient. Okay, so while I'm scrolling and I'm looking at the kidneys, I feel that the attenuation, there is an attenuation difference between the right and the left kidney. Which could be due to focal pyelonephritis, and hence explain the sepsis. I'm also trying to look for perinephric stranding, which should be a feature in cases of infectious process. There is subtle fat stranding, but not very significant. I'm also trying to look at other organs, the visualized part of the liver and spleen within the limitations of an enhanced CT, the adrenals, they look fine. I'm trying to look for any free fluid in the abdomen or pelvis. I cannot see any. I'm looking at the appendix to see if there is any appendicitis or focus of rupture. I can see the blind end, and the appendix also looks normal. So I believe there is the attenuation abnormality within the right kidney, which should be investigated further by IV contrast to see if there is any focal infection within the renal system to explain the sepsis.
So what do you think of this tube here?
The tube, okay, sorry. So the tube, which I could not understand the nature on the X-ray. So I'm first going to look where the upper end is ending. So I could not see the upper end, but however, I'm now going towards the distal end. It splits into two parts, and one part is going it's all coiling within the abdomen actually. Okay, so this end at least is ending in a sort of air-filled, no, these are small bowels. Okay, I'll again try to find the other part. Okay, it goes. It's going behind the spleen. And again, I'm lost. I really cannot ascertain the nature. For a moment, I felt that the distal end has a sort of, is entrapped within an air-filled sac, or is it forming an abscess with its distal end? But this seems to be small bowel loops rather than any. On reflection, it perhaps, because it's a bit of irregular with branches, this could be sort of sealed focal infectious process going on related to the catheter. And I would discuss this possibility with the clinician and to see if this is actually an infectious process going on, and further management by the surgical or the clinical team to be discussed with them.
Okay. So next case.
I think you'll have to press twice because the mouse was with me, maybe.
Oh, but it's running here. So loading.
Okay, then fine. 40-year-old female patient. Sorry, my fault. Should I continue with this or go back? 40-year-old. Yeah, 40-year-old female patient with abdominal pain and vomiting.
Oops. Okay.
So this is a frontal radiograph of the abdomen. in a 40-year-old female patient presented with abdominal pain and vomiting. I can see that this is most likely an upright. Yes, this is an erect view of the abdomen, and it demonstrates multiple air fluid levels within the central as well as peripheral parts. There are prominent small bowel loops as well. I cannot see any free air under the diaphragm. I cannot see any air lucences within the liver or within the biliary tree to suggest air in the biliary tree or the portal vein. I do not see any area of free intraperitoneal air. With the history of abdominal pain and vomiting and multiple air fluid levels, I'll get in touch with the surgical team and the clinical team and suggest that a contrast-enhanced CT abdomen should be the next step for investigating this patient.
Okay, what you are suspecting in this patient?
This could be mechanical obstruction by the adhesions, hernia, or any intussusception, or it could be mechanical or hernia.
Okay, fine.
So the first is the Cardinal CT abdomen, non-contrast. In this patient who has CT abdomen for multiple air fluid levels seen on the abdominal X-ray. I'm going from front to back. I can see that there are dilated bowel loops. I'm trying to scroll through. Once, I'll go back again. I can see multiple dilated bowel loops with fecal material. However, I like to trace the colon to just make sure that the fecal material and the dilated bowel loops I'm seeing is actually the small bowel loops and not the large bowel. And I believe that is so. So this all area of dilated bowel loops with fecal material is actually small bowel fecalization sign. So there is definitely small bowel obstruction. I'm trying to look for the cause. It seems to be in the form of closed loop. So here my main suspicion is to make sure that this is not a closed loop or strangulated hernia, which is a surgical emergency. I would proceed with the contrast enhanced phases of the study. So again, I will start craniocaudally. First, I'll go up. Okay, so this is its axial CT abdomen. Portovenous phase. As I'm scrolling down, I can see again dilated small bowel loops with fecalization sign. I'm trying to look at the vessels, the mesenteric vessels as well. I'm trying to look for the swirling or the sudden area of transition of the bowel loops to see the transition point. So these are the dilated bowel loops. As I go down, I can see the distal ileal loops are collapsed. So at this point, my emphasis is that where is the transition point? These are the distal collapsed loops where my arrow is. I'm trying to find the area where the transition is. I look once at the coronal contrast enhanced CT as well. So there is significant mesenteric engorgement around this dilated bowel loops. So this could be a case of internal hernia as well, which might give rise to this commonly it's via the paraduodenal or along the paracolix, but somehow or other I'm failing to identify the exact point. But anyhow, I will call the surgeon and tell him that this is a surgical abdomen, and the patient should be taken to the OR for the relief of the bowel obstruction in this patient.
Okay. So next case.
So this is a 65-year-old male with palpable right breast lump.
Okay. In that case, which modality would you prefer for this patient initially?
Initially, ultrasound, I would start with the ultrasound in this patient. So this is a 65-year-old male with right breast lump. So I've been provided with multiple selected images. Although the images are not marked, but I believe that this is the right breast, the area of complaint. And what I can see is an irregular, hypoechoic / heterogeneous lesion, which is taller than wide, with multiple calcifications at the site of complaint with vascularity. So in a 65-year-old, I would have a look at the other breast as well. But with all these morphologies, this points towards the aggressive malignant lesion. And I would be very concerned about the carcinoma. So I would contact the clinician, advise a mammogram as well as biopsy to rule out a cancerous lesion in this patient. And if it does, I would also look at the right axilla to see the nodal metastases, if any. And then this patient would be referred to the MDT and further staging. So we have a mammogram, and we can see that there is a soft tissue density lesion with microcalcification in the retroareolar region of the right breast. The compression views have also been done, and it just further enhances the features of speculated lesion. So my prime differential still remains the same, that this is right breast carcinoma unless proven otherwise, and should be referred to a breast MDT with biopsy and staging CT chest in the management line.
Okay. This patient is complaining of pain in the right lower limb.
Okay, so this is these are multiple radiographs of a patient who's complaining of pain in the right lower limb. So I have been provided with pelvis radiograph, with right hip radiograph, 2 views, the right knee. So starting with the pelvic radiograph, I'm looking at both the hips, and I feel that there is a subtle abnormality overlying the lower part of the right hip joint. I'll have a look at the close-up views as well. So this patient is with right lower limb pain. I felt that there is a lucency here in the inferior part of the right femoral head, but when I look at the oblique view, the femoral head looks fine. But this area, ill-defined, does not appear normal to me. I'm looking at I'm trying to see if this is some sort of avulsion fracture, but usually the sites are anterior superior, anterior inferior ischial. So this does not fit into any avulsion fracture either, but this definitely seems to be abnormal. The knee itself, the suprapatellar, the space, the patella itself, the tibial tuberosity, the cortex of the tibia and fibula, and the femur looks fine. So I would talk to the clinician and say that I have my suspicion regarding the right hip joint. I cannot clearly identify the reason, the pathology, but I would advise either an ultrasound or a CT, cross-sectional imaging like CT and MRI in this patient to take the case further?
So the clinician was not doubtful about the hip at all. He requested an MRI.
Okay, so now I have the MRI of this patient with lower limb pain. The first sequences I have is coronal T1 in this patient. I'm scrolling. Okay, so this is coronal T1. Next, I'm looking at coronal stir. And I can see that there are areas of abnormal signal intensity involving the diaphysis of both the femur, more marked on the right. I'm going to go to the axial T1. So, sorry, yeah. So in the axial T1, there are subtle changes, but when I look at the axial stir, so there are areas of abnormal signal intensity in the femur shaft, as we saw before. I would ask the clinician if there is any history of previous hematological diseases, including sickle cell disease or thalassemia, or is there any risk factor for is microischemic injury? One of the differential could be that this patient has sickle cell or thalassemia, and in that case, I should have looked more closely at the vertebral bodies when I was looking at the hip X-ray.
Okay, she doesn't have sickle cell, but she is a military person.
Sorry, she's a
military
person. Okay. Yeah. So actually, the military personnel who undergo rigorous exercise training, they are more prone to stress fractures. But stress fractures usually should be seen as linear hyperintensities, and perhaps this is the area in the upper tibia on the left, which denotes the stress fracture in this patient. So I believe the patient has stress fracture of the tibia and not what I was saying on the femur.
No, but she's complaining of the right side, not the left.
Right side, okay. Okay, I'm looking at the muscles as well, if the rigorous training has led to any muscle injury in this patient. I'm looking at the right femur and the tibia. I'm not sure if this subtle ill-defined hyperintensity denotes a stress fracture, but it's not as impressive as that on the left.
Okay, so what do you think of this abnormality?
In the femur, or
in the femur, yes, this one.
In the femur, it is sort of generalized. It is sort of long segment. So that is why I was thinking of a generalized hematological disease rather than any acute traumatic event. It does not look like a stress fracture. So honestly, I'm not really sure how to explain this with the patient's military history, actually.
Would you recommend anything else for this patient?
A bone scan, perhaps, to see if there is any acute injury. It would show the uptake in this patient.
Okay.
So in this bone scan, we can see that there is an uptake in the mid femur shaft, seen both on anterior and the posterior views. There is also uptake in the proximal and the mid part of the calf. I think the tibial is on both the sides and calf in the other side. So multiple areas of uptake in a military personnel would mean that there is history of that indicates stress fractures in this patient because of over use of the bones. There is also concomitant CT images done in this patient. I'm not sure if I should be seeing them or not.
Right.
But I would, these bone scan are impressive of stress fractures at multiple sites in the lower limbs, which would actually explain the cause of pain as well.
Okay, so last case.
So this is right knee effusion in a 60-year-old female. So this is frontal radiograph of the right knee in a 60-year-old patient with the history provided as effusion. I have the view of the right in multiple obliques and laterals and zoomed up images. So in the zoomed up images, I can see that there is a sort of ill-defined cortical destruction along the medial aspect of the femur with cortical thickening and a subtle periosteal reaction. I'm trying to look for soft tissue component. Actually, I cannot see any soft tissue component. All I can see is cortical irregularity, a subtle periosteal reaction. The feature, I do not see any lucent, well-defined lesion. This is, it is ill-defined. The features are of aggressive nature. So in this patient with effusion, I would be concerned about an infectious process like osteomyelitis. And the next likely differential would be a malignant lesion, although there is no extraosseous soft tissue component, so less likely. The next step here would be an MRI, contrast enhanced MRI for further evaluation.
Okay, can you take a look at the tibia, please?
Okay, so this is the lateral view. Now I'm going to look at the AP view. And through AP view. So I believe in the tibia, there seems to be a sort of defect on the medial aspect and a subtle lucency as well, with loss of the cortical outline on the medial aspect.
You can ignore this first.
Okay, so coming to the upper part, the tibial spines do not look very sharp. I'm not sure if this is projectional or there is sort of avulsion of the tibial spines and the patient has had some sort of traumatic injury. On reflection, I also feel that there's sort of defect in the posterior aspect of the distal femur as well. Not sure if it's related. The fibula also looks okay. So if this is not a true pathology, then I believe the fact that I cannot see the tibial spines very discreetly might be the pathology. And again, an MRI would help in this case.
Okay. So basically, this case, you were right about describing the periosteal action here, but it's also present in here as well.
I cannot see your arrow, Dr. Laila.
You can see it here?
Yeah, yes, now I can see, yes.
Okay, so there is periosteal action here as well.
Yeah.
And here
yes.
as well. Yeah.
Yes.
And
yes.
here as well as. So this is a case of hypertrophic osteoarthropathy.
Right, okay, yes.
Okay. The bony texture itself is normal. So like you said, you focused on the periosteal action, but then you ignored it later on.
Yeah,
But it's present in all bones. So this rules out at least that the abnormality is a primary osseous one, being seen in 3 different bones.
yeah.
So I mean, it's not a mess. I mean, that's what I want to say.
True. Understood.
For this previous case, you were right. The previous images did not show the abnormality. So they were all within normal. And the MRI showed the abnormality here, the area of edema in the marrow edema, as well as the subperiosteal edema. And you were right. Yeah, so this is subperiosteal edema. But it's a good thing that you thought about sickle cell, because even acute bone infarcts can give this picture as well. But the nuclear scan, you were right. These are straightforward for the stress fractures, being linear along the bone and so on. And also focal, they don't take a long segment of the bone, just focal uptake.
Right.
So for the breast lump, you're right. First, this is a male patient, so ultrasound would be a first option. You were right, an abnormal mass, irregular, longer than or deeper than wider, and even on the mammogram, same issue. These are pleomorphic calcifications and BIRADS 5. So always please give the scoring for the breast masses, whether it is a male or female.
Yeah.
Okay. M5, yeah, according to the British M, it will be M. And then this lady, you were right. This is a paraduodenal hernia. It's a left paraduodenal hernia. So the dilated bowel loops, and this is the transition point. This is where you can see that the vessels are going here. Yes. And you showed it on the axial views as well. So here, see this one?
Yep.
It's going straight forward into a narrow loop. So this is the left paraduodenal hernia. How to know a left paraduodenal hernia? You look for the inferior mesenteric vein. This is the inferior mesenteric vein. I think it's one of those. So the left paraduodenal hernia, because always the dilated loops are behind the inferior mesenteric vein, and if we can see, it's joining the superior mesenteric vein. Yes, yeah, this is one. That's the most common anyway.
Yeah,
the most common type.
Right.
And in any case of intestinal obstruction, we have to look for the cause and look for the complications, and urgently picking up the phone, calling the surgeons, and also for the viability of the bowel loops. Yes. Here, because this is an unenhanced scan, so it's difficult to comment on the kidney. This is one issue, one thing. Second thing, you can always ask the examiner if you can check for the other views, although it's not available, but I think an X-ray would have been helpful in this case. Right. For the kidney. This is a VP shunt, like you said, but it's a broken VP shunt. So this is the distal part of it.
Okay.
Yeah, and it's been there for many months, but it's not causing any complications. But I think this is why they requested the CT abdomen in the first place, to check if there is any related collection or bowel perforation or any abnormality related to this VP shunt. They did not remove it.
Right.
And the routine chest X-ray, you were super perfect in that case, Dr. Sarhat. So this is a case of metastasis in the right upper loop and mediastinal lymph nodes. One of them is this anterior mediastinal lymph node and the subcarinal one. And this throws suspicion that there could be lymphangitis carcinomatosa in both lower lobes. There is extensive interstitial thickening. Right, of course, patient also had bronchiectasis and other chronic changes related to the bronchiectasis. But the presence of lymph nodes is highly suspicious that these could represent also lymphangitis carcinomatosa. He had obliteration of the right fossa of Rosenmuller, which is the common location for nasopharyngeal carcinoma. You are right, there is significant asymmetry between both sides, and even the fat veins here are completely asymmetrical.
Yes, yes.
And the lymph nodes. Okay.
Thank you so much, Dr. Laila.
Thank you. Thank you, Dr.
Thank you.
Okay, so Dr. Kanika.
Dr. Kanika, are you here?
Hello, hi.
Dr. Kanika, can you unmute yourself again?
Hello.
Yes, you're good. Okay, thank you.
Okay, Dr. Kanika. So this is the first case. Hello.
Dr. Kanika, can you put on a headphone or something because your voice is echoing? Hello?
Did you see?
Yes, I think it's okay.
Yeah, just press on the image. It will come. Yeah, that's it.
No, it's not. Okay, I think, no, let me check again. Yeah, I think you've sent them. Okay, can you see my mouse, my marker? Okay.
Yes, sir.
So the patient was 30 years old female complaining of I think abdominal pain. I've been provided with a pelvic ultrasound. There is longitudinal view of the uterus, and I think the endometrium has been measured here. And the endometrium looks heterogeneous in signal intensity. However, the outline of the uterus looks normal. I can't see any fluid collection surrounding, in the pelvic space. Well, if I can see the other sequences,
Yes.
just
Sure.
yeah. Yes. Well, this is the transverse image of the pelvis. I think there is, I can see here a rounded image at the lesion of the left, at the site of the left ovary, which is measured about 3 by 2 centimeters, which is heterogeneously hypoechoic in signal intensity. Well, I think there is a mass in the region of the left ovary, and I will continue to see the other views if you permit me to see them.
Sure.
Yeah, yes, these are all in the region of the left ovary. This is in the Doppler image, I can see some increased vascularity surrounding the mass, but there is no any coding, color coding within the mass. So this gives me the impression of torsion of the ovary or an abscess in the region of the left adnexia or region of the left ovary. I will check the clinical picture of the patient if the patient has a fever or the lab markers like PCR and sedimentation is high. The inflammatory markers if high for the view of abscess, and they are normal. Yes. So because of the loss of coding within the mass, these are all let me think of volvulus of the ovary, and this is an emergency, and I will pick up the phone and tell the referring clinician about the situation.
Okay, what do you think of this image here?
Well,
again, it's the left ovary.
Yes, in the left ovary, there is a difference in the echogenicity within the mass. Some are hypo and the others are hyper. So this gives the impression of possibility of infarct within the ovary. Yes.
Any other possibility?
It could be abscess also within the adnexia region. yes, adnexial region, and I'm thinking of two emergency things: abscess or tubo-ovarian abscess or torsion. This causes the acute pain in the abdomen in the young female ladies. However, ectopic pregnancy is another possibility, but I can see okay, or pelvic inflammatory disease in the pelvis. So this is also a possibility.
Okay, so patient did not have her inflammatory markers were normal, and the pain was not so acute that it's just happening over the past week or so, maybe more.
Okay, so long-standing pain.
Yeah.
I will go to see to the to look to the endometrium if it is thickened, because I've seen just it is measured, but I don't know the thickness. It could be due to ectopic pregnancy or endometriosis also is another cause of pelvic pain. So I will ask for MRI in such cases to be sure of this mass from the view of endometrial mass in the ovarian region, because it has long-standing pain. So it could be due to endometrial lesion or endometriosis.
Okay.
Yeah, well, I've been provided with the selected sequence axial image of T2 weighted image. Yes, this is T2 because the fat looks bright. However, there are two rounded structures in the both adnexial lesion regions that are hyper-intense, mostly hyper-intense in signal intensity. This gives me the impression of hyper-intense signal intensity on T1 weighted images could be most probably either fat or blood. But I would like to see the fat suppressed image if possible.
Okay. Sure,
Yes.
they're available.
Okay. Well, I'm trying to. Okay. Well, it is fully suppressed on fat suppressed. So this is fatty lesions, and it gives me the conveys the impression of fatty lesions like dermoid, bilateral dermoid, or teratoma, mature teratoma.
Okay, so how will you manage this patient?
Well, I will convey my findings to the referring clinician, and in order to be discussed in the MDT for the possibilities, because these are benign lesions, but there is a risk of volvulus in these. I mean torsion. Sorry, I mean torsion of these lesions. So it should be managed accordingly.
Okay, so next case.
Well, 5 years old male with respiratory distress. I've been provided with a frontal chest X-ray for a child, a male child of 5 years old. I'm looking systematically to the both lung fields and to the mediastinum. I can see there is paratracheal hyper-dense lesion, which is keeping with the thymus lesion, thymus structure. And I'm looking to the recesses or costophrenic angles. They are well marked. There is hyperlucency on the left hemithorax in comparing with the right side. And when I'm looking to the vasculature of the left hemithorax, it seems to me not equal with the right side. and there is more transradiancy. So I should think of transradiant hemithorax. Either it could be due to chest wall or vasculature or parenchyma, I mean lung, or pleural effusion. As there is no pleural effusion and the vasculature looks smaller than the other side, so this gives me the impression. I will look also control the hyla, if it is a small or big. The hyla, the left hyla is smaller than the right. All these gives me the impression of Macleod or Sawyer-James syndrome. And I will convey my findings to the referred clinician in order to discuss in the chest MDT, because this is due to chronic bronchiolitis. This is a sequelae of chronic bronchiolitis, and it may,
Okay.
yes.
But if the child is presenting acutely, what would you think of?
If the child is presented acutely, so it could be foreign body, but I can't see the foreign body here in the mediastinum. I will ask for the sagittal just to see the cause of the hyperlucency or transradiancy in the hemithorax. So can I see the lateral if possible?
Yeah, sure. Yeah, sure.
I can't see any foreign body in the airways. So this could be a possibility for obstruction by mucus plug, specifically if the patient is asthmatic, or even if the foreign body is not radio opaque, maybe it is a seed or knots. So I should convey all these findings to the referred clinician, because this is also an emergency. If there is a foreign body, for the possibility of the foreign body should be managed quickly.
Oh. So next case.
Thank you. Well, this is 75 years, a patient with raised gamma glutamyl transverse levels in an asymptomatic individual. Well, I've been provided with the ultrasound image. I think it is a transverse image. Most probably looks like a liver. I think the surrounding texture is belongs to liver, and this here is a very well-defined, rounded hypoechoic structure, which includes septations within it. So it is multi-septated cystic lesion because it has also acoustic enhancement in the posterior acoustic enhancement. So it is cystic in nature with the multi-septated lesions, well-defined. This gives me the impression of parasitic infestation like hydatid cyst in the liver. And I will convey these findings to the referred clinician and to be discussed in the MDT, and will ask for chest X-ray for this patient for the possibility of hydatid in the chest, and will be discussed also for the other possibilities, for the other cystic possibilities in the liver. Yeah.
Mm-hmm. Okay, so what would you recommend next for this patient?
I can ask for CT images, if possible, and chest X-ray, of course.
Okay, so this is the CT.
Okay, well, in CT images, I can see.
You can press on the screen to start controlling.
Yeah. Okay, okay. Okay, thank you. Well, I can see a well-defined, rounded, mildly hypo dense lesion in the right lobe of the liver. Okay, I'll go up a little bit. No, there is nothing here. I will continue to go down. Yes, this is a well-defined rounded hypodense lesion, which is not cystic in nature. It is mostly soft tissue in nature. So this is the oral contrast material is there, but it is not enhanced, I think, non-enhanced. So if possible, I would like to see the enhanced CT just to be sure of the nature of the lesion.
Yes, sure.
This one, yes. Well, there is mild septation within the lesion, which are mildly enhanced. Sorry. And very well defined. And I think it is a long-standing lesion because there is no edema in it, and even the vasculature is pushed away. Yeah, this is the delayed images also shows a mild enhancement in the periphery of the lesion. The lesion is lower in density than the liver. This all gives the impression again of long-standing hydatid or abscess, amoebic abscess also in the liver. However, cystic hemangioma also is another possibility, but I will ask for the clinical picture of the patient if he is febrile or from the in order to know whether it is amoebic or parasitic. I mean hydatid. Also, if possible, I can ask for MRI, if possible, just to see the nature of the lesion more obviously.
Mm-hmm. But in the history, it's mentioned that patient is asymptomatic, and also you said that you said that the lesion is solid. You still believe it's solid or cystic? Well,
I think it is. It is not so solid. It is. It is not enhancing, only the periphery is enhancing, and mildly the septations are mildly enhanced. So I think this is abscess, amoebic abscess, or long-standing hydatid, or cystic hemangioma also could be there. The liver, the surrounding liver looks normal, and the outline of the border of the liver also looks normal. So I can't think of hepatocellular carcinoma in a normally normal liver parenchyma. And when I look to the other structures, the surrounding structures, there is nothing remarkable in the liver, in the kidneys or the mesentery. I'm trying to look downward if there is any other possibility. So this is hepatic lesion of low density. Also, there is, yes, it is not a cystic in nature, I think. This is a soft tissue. So if it is long-standing, so I should think of a well-defined rounded lesions in the liver. So it could be adenoma or fibrous FNH, in the liver. And yes.
Okay. How would you manage this patient?
Well, it should be discussed in the MDT for the possibility of biopsy of the lesion, if it is FNH, or it could be also hemorrhagic adenoma or cystic adenoma, and for booking for an MRI to see the signal intensities of the lesion. But it is benign outlined lesion. Yeah.
Okay, so next case.
6-month-old child presents unwell with increased work of breathing, respiratory infection, suspected respiratory infection. I've been provided with the frontal chest X-ray of a 6-month-old child. I'm looking to the mediastinum and I can't see anything remarkable in the mediastinum. However, in lung, on both hemithorax, there is increased reticular markings, specifically in the mid and upper zones of both hemithorax. The lower zones on both sides, there is, I can see reticulation in the parenchyma of the lung. I'm looking if the patient has any pneumothorax or pleural effusion. The costophrenic angles, specifically on the right side, looks translucent. The patient has, okay, the patient has respiratory distress, so there is a possibility of, and 6 months old. I'm looking to the ribs. Yes, there is irregularity in the ribs, multiple ribs, specifically on the left posterior ribs, starting from the 4th, 5th, 6th, 7th, multiple ribs. I think there is all the fracture in these ribs, posterior ribs. Also on the right side, I can see in the mid posterior ribs also irregularity. This gives the impression of non-accidental injury or abused child. So with the respiratory distress, I should call the referred doctor, because this is a medico-legal problem, and I should examine and book the patient. I should look to the other bone for bone survey, and will look to the eye pupils for the possibility of papilledema, and also CT scan maybe of the brain could be needed to see other multiple lesions, possibility of other lesions, because the patient is, there is a suspicion of non-accidental injury of this patient due to posterior multiple old fractures in the ribs.
Okay, so the patient did have a CT?
Okay, so I will look to the CT just to, okay. Is it scrolling? Okay, yeah. So I'm going caudally. Well, there is diffuse hypodensity in both sides, and there is increased, yes, hypodensities. I think there is diffuse edema in both cerebrum, and this is non-enhanced CT. However, there is increased density in the dural reflections, specifically posteriorly, gives the impression of subdural hemorrhage. Also, the lateral ventricles looks effaced. So these all are brain edema, could be the possibility of brain edema. I should look to the skull if there is any fracture in the skull. However, this is not bone window, but there is edema in both centrum semiovale and the cerebrum. And there is some hyperdensities in the tentorium. I think these all also gives the impression of non-accidental injury or abused baby child.
Okay, so next.
So this is a medical legal case.
Okay.
15 years old male of 4 weeks intermittent left lower quadrant pain. On examination, a mass was palpable in the left lower quadrant. Yes, this is an ultrasound of the left kidney, shows hydronephrosis of the pelvic-calyceal system. I'm looking to the parenchymal thickness. It could be a little bit thin. I'm not sure. I should compare it with the other kidney. However, there is enlargement of the kidney. It is 14 centimeters in length. So it looks bigger than the age of 15 years old child. And there is hydronephrosis. So this gives me the, I should think of the possibilities of hydronephrosis in 15 years old child. Either it could be stone or clot or sloughed papillae or reflux, vesico-ureteric reflex, or obstruction at the pelvic-ureteric junction obstruction. So I need to see the whole ultrasound along the trace of the ureter to the bladder to know if the bladder also, if the ureter is also dilated, because I can see here hydronephrosis. This is a case of hydronephrosis. And I should know if it is obstructed hydronephrosis or due to reflex. So,
okay. So what will you recommend next for the patient?
I will recommend CT for the patient, if possible.
Okay.
Yeah, well, there is a huge hydronephrosis, massive hydronephrosis and hydroureter. The ureter looks hugely dilated and turned around. However, I can see the lower end. Can I, okay, scroll. Yes. Oh, well, where is the, okay. See? Mm-hmm. Yes, a huge dilatation of the, okay. I want to see the end of the ureter. The ureter is, I wonder if these are all due to ureter or it is, I'm just trying to scroll it. I think I'm looking whether it is a duplex system or well, I can't decide because there is a huge dilatation of the pelvic calyceal system, and there is another tortuous round structure in the left lower quadrant. Well, with that I can't trace it downward to the bladder. However, there is a linear, I think this is vessel. So is there an axial?
So no, unfortunately, it's not available.
Okay.
What will be your, did the CT limit your differential or is still the same?
Well, there is hydronephrosis, massive hydronephrosis with in the same density, there is a cystic lesion below the left kidney. I couldn't follow it till the pelvis, so it could be due to the, it's part of the hydronephrosis, or it is a cystic lesion within the kidney also. So, but this is an emergency. I should ask the nephrologist or the referred clinician for the nephrostomy, because there is a huge hydronephrosis here. I think this is part of the ureter, also is hugely dilated, or mega ureter in the region. If there is an axial images, I can display it much more, and I will understand the situation much better, because it is extending down to the iliac fossa, iliopsoas fossa, and there is mild septation within it. So this is septated lesion, which is in continuous with the kidney. So,
Okay.
yeah.
If you follow here the images, I feel that the the ureters here, they are continuous together. So I believe this is a ureter.
Okay.
Can you suggest what the possible reasons for this to be?
It could be hydroureter, or it could be to end stage of vesico-ureteric reflux, or there is an obstruction downward in the lower part of the uterus, which gives this, or also hydroureter, megaureter, I mean.
Okay. So do you recommend any further investigation?
Well, I can see if there is contrast enhanced CT, axial CT, just to see, or MRI.
What will the MRI add?
CT is much better, just to see also if there is any calculus or stone down in the lower part of the uterus, which causes such obstruction.
Okay, fine. So next case.
Okay.
Last case.
55 years old male with health history. Okay, I've been provided with selected axial images of cranial CT. I think it is, yes, non-contrast enhanced.
Yes, okay.
Okay. No history was given in a 50 years old male. I'm trying to look from craniocaudal to the images. I'm looking to the brain parenchyma, to the gyri and the ventricles, midline. I'm trying to see if there is any effacement or any hemorrhage, or because there is no any history, so I'm trying to see if there is any. I'm looking to the posterior fossa, and here there is ectatic vertebral artery, which is going to the left side. Oh, I'm trying to scroll it up. Ectasia, yes, of the vertebral artery. However, I can see some dense artery in the. Okay, I'm trying to see if there is any dense artery. No midline shift, no hydrocephalus. Looking to the cerebrum, if there is any mass lesion in the cerebrum. To the circle of Willis, I couldn't see any aneurysm. However, there is some hyperdensity in the region of the internal carotid, I think, yes. No, this is not intercarotid, this is in the basal, yeah.
Okay, so this patient was having neurological symptoms, acute neurological symptoms, and drowsiness.
And drowsiness.
Mm-hmm.
So this, I'm looking to the posterior fossa and to the basal artery. However, there is some density here in the bifurcation of the basal artery, or here in this region, in the tip of the basal artery, and this gives me the suspicion of aneurysm or thrombus, sorry, not aneurysm, thrombus in the tip of the basal artery. So, and because of the patient is drowsiness, and I will convey my findings to the referred clinician, because they may need thrombolysis or thrombolectomy. There is a possibility of worsening the situation of the patient because of this risk. It is risky for the, he may go through to proceed to the coma because of this thrombosis in the tip of the basal artery. I haven't seen any other emergent thing, but this is really emergency. So I will inform either the referred clinician or interventional radiology to do the possible things regarding thrombolysis.
You will not do anything else? I mean, are you sure it is a thrombus?
It is dense. Well, I can do, is there a window, stroke window to see the density, or I will change the window if possible to see if it is really dense or not.
Okay. Okay, fine. So, Dr. Noor, this was the last case.
Okay.
I disagree regarding the density because all the vessels are dense, even this one as well. If you go a little bit, you'll find that the middle cerebral, so all of them having the same density as the basilar. But you are right about saying if you are doubtful. So whenever you are doubtful, try to make sure. It's good that you mentioned that you want to see the stroke window.
Yeah.
And also because there is no edema and there is no mass effect, it's better to make sure. We should have taken this patient to MRI to make sure what's going on here.
Okay.
So this is the whole point. So this patient did have a small infarct here, and these were all normal vessels, just congenital variation in the vessels.
Okay.
Okay. One more thing, whenever we are discussing the case, so this is a sequence, and the examiners and even the invigilators, they will tell you, do not scroll until you are told so. Whenever there is a scrollable image, they will tell you to start scrolling. Take it easy. Start from the way that if you take it codocranially or craniocaudally, tell them I'm scrolling in a craniocaudal fashion or a codocranial fashion. And you are speaking while you are scrolling so that your eyes take time to see all the sequence. Don't just focus on the abnormality and leave the rest of the sequence. Not specifically in this case. I will show you in the previous case. I will show you in one of the cases. So this one, you were right. So this child is having hydronephrosis and the kidney is enlarged. You mentioned it could be hydroureter due to stone, or it could be vesicuretric reflux, or it could be megaureter. And those are or dilated PUJ. So you are right about the four. The CT ruled out the PUJ. So this is not PUJ, the entire ureter is dilated. And then you have three more differentials that you yourself mentioned. So look for the stones. There is no stones here. So you are left with two options. Either this is a hydroureter due to other obstruction, vesicuretric reflux, or megaureter. So take it in stepwise. You need to exclude or rule out both possibilities. Which one you will do? So you will say that I will request the contrast study. This is a contrast study, so this is a portal vein. I know the sequence is not, the image quality is not so good, but this is a portal venous scan. So you say, I will check or wait for the delayed sequence to see if there is excretion or not, and wait to see the urinary bladder full. If you're suspecting vesicuretric reflux, then you will do a nuclear study for the vesicuretric reflux to see if it is there or not, or ascending cystogram.
Okay, thank you.
Okay.
And what was this case?
This was a megaureter.
Okay, thank you.
So this child, you were right. This is a child abuse. Take it in a systematic way, like you said. For example, you checked on the lung windows first, and then you check the lung fields first, and then the costophrenic angles, and then the ribs, and then when you notice that the ribs have multiple fractures, you suspected it. So you are right to request the pediatric team, and this is a medical legal issue. So, and also the child protection services. You also will not allow the child to leave the department. What else? And then, and yes, and for the secreted survey and the scan. The CT scan here, you mentioned this is a subdural hemorrhage and the diffuse edema of both cerebral hemispheres. Okay, so try to take it quickly, as I mean, so we don't need to repeat the findings. So these are the subdural and this is edema, so the child is need urgent referral to the pediatric neurology team, and that's it.
Okay, thank you.
So this is the case when I wanted to tell you, scroll all the images. So this one is a single image, but I don't think this is cystic because there is a hyperechoic content here.
Okay.
I believe this is solid even on the ultrasound. And again, when you mention if find a scrollable image, you say I will scroll in a systematic, in a craniocaudal direction. This is what I also said in the exam. So I can see that the lesion is here. It's a slightly hypodense, and the surrounding liver parenchyma is normal. Go down. Don't stop. Don't stop. Check all the structures until the sequence ends. You will find that there is another lesion here.
Oh,
so this is a para-aortic lymph node. And scroll until you reach the end of the study, so that you have satisfied it completely.
okay.
So this is a case of lymphoma. So this was a lymphatic tissue, and this was a hepatic lymphoma as well. Of course, we cannot tell this on CT, but we would say that this is a lesion. This is solid. It cannot be hepatocellular carcinoma, like you said, and that we need a guided biopsy for this lesion.
Okay, thank you. I never seen such a case. Thank you.
Sometimes there are lots of cases in the exam that are either unsolved or we didn't see before. But you just have to manage it the same way as you do in your department.
Yeah.
So you're right about this. Yeah. So if the child is presenting chronically, yes, this would be a pan-bronchiolitis, and this is a transradiant pneumothorax. If the child is presenting acutely, this is a foreign body inhalation, and this was a case of foreign body inhalation. And it's a surgical, it's an emergency, of course.
Okay, is the foreign body seen in the lateral view? I haven't seen any foreign body, so it is not radio opaque. Okay, okay.
Exactly, it's radiolucent, yeah.
Thank you.
And lower abdominal pain in this patient. So the uterus was fine. Yes, I agree. There's some heterogeneity here. But here, when looking at the ovary, so you can see that the ovary is heterogeneous, and the echogenic part is on top of the hypoechoic part. This is a sign that is suspicious for fat content.
Okay.
Even if you're not convinced, put it in the differential as well. So you say it could be torsion, it could be an ovarian dermoid, it could be an abscess. If the inflammatory markers are normal, then we are left with the two other possibilities. Either it's a dermoid, simple dermoid, or a torsion, whether it is due to MS or not. Okay. And on the MR, this is a T1 case, and those are hyper intense that are suppressed. So these are dermoids. Continue your analysis. There is no enhancing components, so it's likely a benign dermoid cysts noted bilaterally. Again, like you say, this patient should be referred urgently to the gynecological team, because these should be notified for further management. They can cause adhesions, they can cause rupture. They do surgery for these. I think some ovarian sparing surgery is done, but these should not be left even for follow-up.
Okay, okay, thank you. Very nice cases, as if I am in a real exam. Sweating and shivering.
I felt so. Just take it easy. Don't worry.
Okay.
Okay, fine.
Kanika, can you check your mic, please?
Yeah, hello. Yeah, can you hear me?
Yeah, loud
yes,
and clear. Thank you.
Is it fine, like voice?
Yeah, it's fine.
Yeah,
it's perfect.
okay. Okay, thank you.
Okay, Dr. Kamika.
Yeah, this is a case of a 3-day-old term baby male presented with abdominal distension. I can see a frontal abdominal X-ray of a 3-day-old male patient, and I can see that there are few dilated loops present in the abdomen, although they are not hugely dilated, but I can see that there are bubbly lucencies in the wall of the dilated loops, for which I have a suspicion of necrotizing enterocolitis. And I am looking at the liver region for any linear lucencies, which I am unable to see. I am not able to see any free gas under the diaphragm and other signs like Wriggler sign or football sign to account for the perforation. If I'm checking the inguinal regions, I'm not able to see any loop of bowel there. So for this X-ray, for this presentation, my suspicion will be necrotizing enterocolitis, and I will phone the referring neonatologist about the condition, and so that they can manage the case as early as possible.
Okay. So next case.
Okay.
So in this patient, they were screening for a primary.
Okay, I can see the MLO view of the right breast. And
You can, okay.
Yeah. Do you want to show me, or can I see myself?
No, you can choose them.
Okay. I can see the MLO view of the right breast, and this is a MLO view of the left breast, and craniocaudal view of the right breast, the craniocaudal view of the left breast, and this is, I think, craniocaudal view of the left breast, and looking more carefully, I can see that this is a heterogeneously dense breast, and in the axilla, I can see a benign looking lymph node, but in the breast, I'm not able to see any opacity. In the left breast, I can see that the fibroglandular tissue appears more dense as compared to the right, and I am carefully looking for any microcalcifications. Both the nipples are looking normal, and
this is a sequence, by the way. So you can
yeah,
scroll
this is a tomosynthesis, and onto the left breast, I can see a few of the calcific densities present, although they are not present segmentally. They are not in the segmental distribution. So I would, since it is a screening mammograph, I would like to ask the patient for another visit for spot compression view of this region, and also for ultrasound examination because although I'm not able to see any characteristic microcalcification, but I would like to see the spot magnification view to look for any other abnormality.
Dr. Kaniga, do you remember the history?
Screening
Screening for
mammogram.
primary.
Yeah,
For
screening for
primary, they are looking for a primary.
yeah.
So are you comfortable with sending this patient home?
No, I will make the patient to do the spot compression view of the left breast and look for the spot compression view and also ultrasound examination, because I can see few calcifications here. And although I'm not able to see any big mass lesion or any speculated lesion.
Okay. Okay. You don't change your mind?
Onto the right breast, I can see there is a focal, on the tomosynthesis image, I can see there is focal asymmetry in the retroareolar region. And there are few speculations around it. So although which is also causing the I think the nipple is retracted a little bit towards it, towards the lesion. So I am suspicious of any neoplastic process going on here. And for this, I would like to further examine the patient by a spot compression view and ultrasound examination and ultrasound guided biopsy if I found any particularly convincing features on ultrasound.
So next please.
This is a 65-year-old female who has presented with abdominal pain for 12 hours and which is getting worse for last 3 hours, and history of right radical nephrectomy due to renal cell carcinoma 20 years ago. Okay. So this is a frontal X-ray of the abdomen of a 65-year-old woman. I can see the right nephrectomy clips. And since this patient is presenting with abdominal pain, I would like to look for the reason for that. And I'm not able to see any particularly dilated bowel loops, but on the in the region of the right, can I see the other images as well?
Yeah, sure.
So on the right upper quadrant, I can see there is a lucency, which is
you can ignore that part.
Okay, which is not looking like linear lucencies to suggest pneumobilia, but looking at the other part of the abdomen, I can see that there is the central part of the abdomen is not showing any significant bowel loops. So it appears as if there is any mass lesion in the central abdomen, and which is displacing the bowel loops peripherally. So the bones appears normal. I'm not able to see any lytic lesion in the bones. Given the prior history of RCC in this patient, I cannot see any pneumoperitoneum. I'm not able to grab anything more from this film. So
Okay.
to know the further, I would like to go ahead with the cross-sectional imaging in the form of contrast-enhanced CT scan. So this is a ultrasound image of the left kidney, and I can see that on the.
These are scrollable images, by the way.
Okay, thank you. So I'm scrolling the images to see. So this is a urinary bladder with the catheter, and this is the this is a right nephrectomy site, and this is a left kidney, and which shows a small cyst in the upper pole, and the lower pole of the left kidney shows a hypoechoic well-defined mass lesion, and so basically from the ultrasound image I could gather that there is a mass lesion in the left lower pole of the kidney. So since this patient had a previous RCC, so can I see the color Doppler
Yes.
images as well? Thank you.
Yes, please.
So the color Doppler image appears to be centered on the mass lesion, which is seen in the left lower pole. So this appears to be whether there is a synchronous lesion on the left side, which can be left RCC, since this patient had previous history of right-sided RCC, and which could be the reason of displacement of the bowel loops and the pain in this patient.
You think this Doppler enhancement pattern or Doppler flow pattern fits with an RCC?
This this Doppler flow pattern is it's low resistance flow, but the way it is completely filling up the lesion, this could be renal aneurysm, but it's too big to be.
Okay.
Yeah.
So what will you recommend to further elucidate it?
I would recommend a contrast enhanced CT scan to look for further evaluate this case, and I mean, I want to confirm the region of this lesion. Is this that mass lesion only, that left lower pole mass lesion, or is it any aortic aneurysm?
Okay. So this is the scan.
Okay, so I can see that this is a I'm going cranially, so I can see this is a contrast enhanced CT scan, and I'm following the descending aorta, descending abdominal aorta. So I can see that the abdominal aorta is quite dilated in the abdominal part, infrarenal abdominal part, and there is extravasation of the blood and rupture of the aorta at the right side, So this is a case of ruptured aortic aneurysm. I can see that there is a retroperitoneal hemorrhage in this case, and the left kidney appears normal with a small cyst in it. So this acute abdominal pain could be because of the ruptured aortic aneurysm, which is a emergency condition, and I would pick up the phone and call the referring emergency consultant to urgently manage this case with the help of vascular surgeons.
Okay. So next please. So this patient has a CT done for evaluation of a mass. Unfortunately, we don't have the X-ray.
Can you please repeat why for the evaluation of
A mass?
a mass? Okay. So this is a contrast enhanced CT scan, and this is a scrollable image. So I am scrolling craniocaudally. I can see the thyroid appears normal and the neck vessels appears normal. As I come down, I see that this is the arch of the aorta, and this appears to be right-sided aortic arch, and the pulmonary vessels appears normal, and the left atrium, the left ventricle appears normal. And the liver and spleen appears normal. The celiac trunk appears normal, and the kidneys and vessels appears normal.
There are more axial images in the abdomen.
Yeah, I'm trying to go down. Okay, not in this phase.
No, yeah.
Okay, I'm not able to go down. So this is, I'm going cranially, and the urinary bladder appears normal. I'm not able to see any mass in the abdomen, but I would like to see the bone window to look at the sacral region in this case.
Yeah, sure.
Yeah. So in the bone window, I can see that the sacrum is showing a lytic destructive lesion in the body of the sacrum, and which has soft tissue component associated with it. And it can be because of the lytic metastasis, or it could be because of the chordoma, but chordoma occurs more inferiorly from the coccyx region. So I want to see the coronal, and this appears almost same. There is no addition, and to look for the primary mass lesion, I want to see the coronal of the arterial phase. I'm looking at the aorta, which appears ectatic in the thoracic region, and Um, so I'm not able to see any primary lesion yet. I would like to concentrate.
So you are suspecting it is a metastatic deposit.
In
Any
the
other
sacrum.
possibility?
The other possibility could be a chondrosarcoma, but the matrix doesn't appear like that. And other possibility can be a plasmacytoma. I'm looking at the breasts, but I'm not able to see any characteristic mass lesion.
Okay, so what would you do next for this case?
Since I'm not able to find any primary lesion on the CT of chest, abdomen, and pelvis, I would try to take the biopsy from the site of metastasis to look for whether that is a primary lesion or is it a metastasis, and I can get an idea of which primary it could be from, and will refer this patient to the ortho MDT for the lytic lesion which I could see in the sacrum for further management.
Okay. Okay, fine. So next case.
This is a 40-year-old male which has raised prothrombin time and with alcohol excess and raised prothrombin time and query cirrhosis. So this is a frontal radiograph of the abdomen of a 40-year-old male with alcohol excess and deranged prothrombin time. So I can see that there are pancreatic calcification seen in the midline at the level of L1, which can be because of the chronic pancreatitis, which generally takes place in alcoholic patients. And I can see that the bowel loops are quite prominent, the transverse colon and the descending and sigmoid colon appears unremarkable, and there is gas in the rectum, so I'm not suspecting any obstruction, like colonic obstruction, but
do you think the position of the transverse colon here is okay?
No, that transverse colon should have been like a little up. So this is as if it is pushed by as if it is pushed down by any space occupying lesion.
Mm-hmm.
So yeah, if I see carefully, I can see that the region near around the upper abdomen is not showing any bowel markings, so there can be any space occupying lesion in that region, and I should investigate further with a cross-sectional imaging to look at that region more specifically.
Okay. Which cross-sectional imaging would you do?
First, I will go ahead with the contrast enhanced CT scan if the patient's renal functions are okay. So this is a contrast enhanced or this is an unenhanced CT scan of the abdomen. I am going cranially and I can see that the contour of the liver appears normal. It is not showing significant nodularity to suggest cirrhosis. And both kidneys appears normal. However, in the pancreatic region, I can see many calcification in the parenchyma, and also the pancreatic duct appears dilated, which is expected in a chronic pancreatitis case. But along with that, I can see that the head of the pancreas shows a well-defined, large soft tissue density lesion, and there is surrounding fat stranding in the mesentery, and
So what would you think about this hypodense lesion?
this could either represent a pseudocyst from any previous bout of acute pancreatitis, or it could be because of any pancreatic malignancy. But given the current scenario, it goes more in favor of a pseudocyst of pancreas. And
okay, how can we differentiate?
First thing is, it is quite well defined, and it has a slightly like a wall around it, and there is a fat stranding around in the mesentery, and there are no intrahepatic biliary radicals dilatation, which would have been.
Okay, would you like to check the contrasts?
Yes, yes, thank you. So looking at the contrast enhanced image, I can see that the lesion is taking up the contrast, and the pancreatic duct is quite enlarged, I mean dilated, and there is intrahepatic biliary radicals dilatation seen, and
so what's your differential for this mass now?
This mass is looking more like a aneurysm arising from any vessel, rather than rather than a pancreatic malignancy or pseudocyst. I can see it is communicating with the communicating is with one of the arteries. So
I'm sorry, again, you said an aneurysm?
as if it is arising from one of the arteries, and it can either be an aneurysm or can be a mass lesion of the pancreas.
Any relation to the chronic pancreatitis?
Can you please repeat the question, please?
Any possibility, any relation to the chronic pancreatitis?
Can be mass forming chronic pancreatitis, or it can be.
Okay, so what would you do next for this patient?
To rule out any communication with the artery, I would like to go for the angiography, mesenteric angiography, to rule out whether it is not an aneurysm. And I'll do the pancreatic cancer markers, and would like to take this case to the upper GI MDT to discuss further.
Okay. Okay. So last case.
Okay. This is a 60-year-old female with a known and operated case of breast cancer, workup for the metastasis. So I have been provided with a contrast enhanced scan of a 60-year-old patient, which is a known case of breast cancer, has been operated upon. I am going craniocaudally. Scrolling this case, I can see a small thyroid nodule and on the right side, and then going caudally. I'm looking at the liver, and cannot see any mass lesion in the liver, and the pancreas also appears normal, and the kidney shows a benign looking cyst. The right breast appears normal. The axilla appears normal. I want to see the lung window and the bone window for this patient.
They're not available.
Okay. This is a contrast enhanced portal venous face, and
Okay, so allow me, Dr. Kanika.
I can see a small focus of low density in the liver.
What do you think of this one?
Oh, yeah. I think this is a right adrenal lesion, left adrenal lesion, and this is a well-defined adrenal lesion, which is showing a low density in it. So I would like to take the Hounsfield of this lesion. If it comes out to be in negative Hounsfield unit, this could be well because of myelolipoma, and I would like to see for any previous CT scan available of the same patient to compare this lesion from the previous scan about its growth. And
can you scroll the images a little bit?
No, this is not, this is renal. Would like to confirm it on a coronal section, if you allow.
Okay, sure.
This is abutting the left adrenal, lateral limb of the left adrenal, but this is not arising from the left adrenal. This mass appears to arise from the gastric wall, but it is an exophytic lesion to the gastric wall. And so either it can be a gastric metastasis. However, the gastric metastases are generally seen in the mucosal region as a
Okay, so what
but
other possibilities?
other possibility for it could be a GIST, gastrointestinal stromal tumor, or it can be because of gastric leiomyoma. And
Okay, so how will you manage these patients?
This, yes, hello, can you hear me?
Yes, how you will manage these patients?
Yeah, this since endoscopy can be done for this patient, and biopsy can be taken from the lesion to understand its etiology, and this case needs to be referred to the GI team for further management and to characterize the lesion. So
okay, fine. So you are right about this case. It is not suprarenal in the coronal, so that even on the axial, but just by scrolling a little bit, you notice that it's separate from the suprarenal. It's compressing here. Like you say, metastases in the stomach are likely submucosal. They will not be exophytic like this, but still it is a possibility since the patient is having a non-primary already, and GIST is another possibility. I'm not sure about endoscopy, if they can see this lesion. I think maybe if endoscopy is assisted with ultrasound, then it can be seen and targeted biopsy can be taken. And this was a GIST tumor. Just for small piece of advice, try to train yourself, all of you, to manage the cases, at least 3 cases in 15 minutes. And like Dr. Kurtz said, be proactive. So you discuss the findings and the management and finish off the case. Just don't make pauses, long pauses in between.
okay.
Okay. So this case here, you were right about the calcifications here. So they are suggestive of chronic pancreatitis, even without the history of alcohol. The position of the colon could be normal, but could also be abnormal, especially that this area is gasless. So this is a case of chronic pancreatitis. We did not see the ultrasound. One of the complications of ultrasound is the pseudoaneurysm, and this is a case of aneurysm. It doesn't need any angiography because it's already, this contrast is a very, very intense contrast, taking it's a venous phase, like the venous phase, similar to the venous side. But anyway, this is a leaking vessel that collects contrast here in this manner. So this is a pseudoaneurysm. It is not common for the small arteries to make aneurysm in this location. And in the setting of chronic pancreatitis, we have to think of pseudoaneurysm. To manage this patient, this is an emergency. So you have to refer the patient, not for the referring physician, or you can inform the referring physician, of course, but you have to refer this patient to vascular surgery and interventional radiology. And whenever there is a possibility or a role for interventional radiology, do mention them.
Okay.
Okay. So this is an extreme emergency, as this could leak or could rupture anytime. Of course, the chronic pancreatitis sign here, the duct is dilated and the intrahepatic venous radicals as well are dilated. Okay. So the previous case. So this case, you are right here, that there is a sacral mass in this patient. And you gave a good differential. It is chondrosarcoma, but it's not a chondrosarcoma because of the absence of the matrix calcification. Could be a plasmacytoma and could be a metastasis, could also be a chordoma. And so this patient needs to be referred to the sarcoma MDT and for guided biopsy. But the scan is mentioning, is bringing the chest consistently because of this right-sided aortic arch.
Yeah.
So it's just an incidental finding that you need to measure, need to tell. Okay. And this patient, so you are right about the opacity. You have seen it in the end of the central opacity in the abdomen.
Yeah.
And you recommended, because the patient, of course, is having a sharp pain only in 12 hours, you initially recommended cross-sectional imaging, which I agree with you. They have done ultrasound. But then you suggested that this is an abdominal aortic aneurysm and that it is already ruptured. So better take the case in an emergency fashion as well, like in your emergency setting. If you see this case in your department, you will pick up the phone, you will call the vascular surgery and interventional radiology and refer this patient urgently. Okay.
Okay.
This patient did not do the contrast study, but of course, while the patient is in your department, you will continue the scan and do the contrast study just to know the true extent and the true size of the aneurysm, because we cannot tell it here on the axial section. And then refer the patients as usual. And of course, you mentioned the retroperitoneal hemorrhage, the high density collection in the retroperitoneal. So these are all positive findings. Else, I think this is far enough. So you are telling that it is an aneurysm, it is leaking, and the emergency, you will have to pick up the phone and call the vascular surgeon immediately.
Yeah. In this nephrectomy thing was red herring. I was consistently thinking about the nephrectomy.
Yes, I agree with you. But the nephrectomy was 20 years ago. It's unlikely to be the reason for anything. And you have already spotted the aneurysm. So this is the focus of the study. Okay. Now for that case, this patient, they were screening for a primary. She had a metastatic deposits elsewhere, and they were looking for the primary. Just for the initial look, you notice that there is asymmetry between both breasts. So there is an opacity here, and it's dense. And on the right side, when you looked at the this one, the tomography sequence. So the tomography sequence confirms that there is an opacity here that is causing architectural distortion. So this patient is having bilateral abnormality in the breasts.
Okay.
This is one, and the second is here. Okay.
Yes.
Architectural distortion, asymmetry, and increased density in both breasts. The usual scan. This patient, you should not let her go home. Do not tell her I will send for a follow-up visit. By this way, you lost the patient. So for this patient, you urgently refer her for the ultrasound for evaluation of the breasts, and according to the findings, maybe ultrasound biopsy could be guided.
Okay.
This patient did have bilateral carcinomas in both breasts. I think that abnormality also, she had lymph nodes and infantile carcinomatosis, I think. Yeah. So again, there is full interstitial thickening and multiple nodules in both lowers.
Lymphangitis.
Yeah, so she did have lymphangitis carcinomatosa and bone metastasis as well. Lytic and sclerotic.
Yes.
Okay. But the most important thing that the history and the parenchymal asymmetry. So it could, even if we don't know if it could be bilateral, at least mention that there is some abnormality in the mammogram and this patient needs to go for ultrasound.
Okay.
Okay. The previous case, you were very much right. This is a case of necrotizing enterocolitis. And again, this is an emergency. So we need to inform urgently the pediatric ICU team and the pediatric surgery team as well.
Okay.
Okay,
Okay. Thank you very much.
you're most welcome.
Thank you
Good
very
luck for
much,
all of you.
Dr. Laila.
You're most
Thank
welcome.
you.
Most welcome, Dr. Saha.
They were brilliant cases, and thank you for all the time. Thank you,
Thank you.
everyone. I think we'll end the meeting
Thank you
now.
all,
Thank you
and
so much.
good luck for you. Okay.